Welcome to the lesson on supporting oxygen. As you have just finished the lecture on assessment of the thorax, lungs, heart, and vascular system, we shall move on to a more in-depth look at the alteration in respiratory function. The respiratory function can be altered by conditions that affect airway patency, the movement of air into or out of the lungs, the diffusion of oxygen and carbon dioxide between alveoli and pulmonary capillaries, or the transport of oxygen and carbon dioxide via the blood to and from the tissue cells. Before we dive in, let's first discuss the differences between ventilation and respirations. These words seem synonymous, but they do differ greatly. Firstly, ventilation refers to air moving into and out of the lungs, while respiration is the process of exchanging the gas oxygen and carbon dioxide. Ventilation has a cycle of inspiration and expiration that facilitates the process of respiration. Respiration cannot occur without ventilation. Ventilation involves lungs and diaphragm, while respiration utilizes the respiratory surfaces such as alveoli and capillary walls. So now that's all cleared up, let's begin with conditions that affect ventilation. A completely or partially obstructed airway can occur anywhere along the upper and lower respiratory passageways. Upper airway, which is the nose, pharynx, or larynx, obstructions can occur when a foreign body, like food, is present, when the tongue falls back of the throat, when a patient becomes unconscious, or when secretions collect in the passageways. Lower airway obstructions involve partial or complete occlusions of the passageways in the bronchiole and lungs, most often due to increased accumulation of mucus and inflammation exudate. Assessing for and maintaining a patent airway is a nursing responsibility, one that requires immediate attention. Partial obstruction of the upper airway passages is indicated by low-pitched snoring sound during inhalation. Complete obstruction is indicated by extreme inspiratory effort that produces no chest movement and inability to cough or speak. Look for sternal and intercostal retractions. Lower airway obstruction is not always easy to observe. Stridor is a harsh, high-pitched sound heard during inspiration. Normal breathing pattern, eupnea, is quiet, rhythmic, and effortless. Tachypnea, rapid respiration, is seen with fever, metabolic acidosis, pain, and hypoxia. Bradypnea is abnormally slow respiration rate, which can be seen on clients who have taken narcotics or sedatives, who have metabolic alkalosis, and have increased intracranial pressure from brain injuries. Apnea is the absence of breathing. Hypoventilation is caused by slowed and/or shallow breathing that can occur because of diseases of the respiratory muscles, drugs, or anesthesia. This can lead to increased levels of carbon dioxide, hypercarbia, or low levels of oxygen, hypoxemia. Hyperventilation is increased movement of air into and out of the lungs. The rate and depth of respirations increase and more carbon dioxide is eliminated than produced. With metabolic acidosis, the body tries to compensate for increased metabolic acids by blowing off acid in forms of carbon dioxide, as demonstrated with Kussmaul's breathing. Hyperventilation can also be a response to stress and anxiety. Cheyne-Stokes respirations is rhythmic waxing and waning of respiration from very deep to very shallow with short periods of apnea, commonly caused by chronic diseases, increased intracranial pressure, or overdose with drugs. Biat, or cluster respirations, is shallow breathing interrupted by apnea, seen in patients with central nervous system disorders. Moving along to conditions affecting diffusion. Impaired diffusion may affect levels of gases in the blood, particularly oxygen, which does not diffuse as readily as carbon dioxide. Hypoxemia, reduced oxygen level in the blood, may be caused by conditions that impair diffusion at the alveolar capillary level, such as pulmonary edema or atelectasis, or be on low hemoglobin levels. Clinical manifestations can be found in your fundamentals book on page 1248, halfway down the page in a box. Hypoxia symptoms are rapid pulse, rapid shallow respirations and dyspnea, increased restlessness or lightheadedness, flaring of the nares, substernal or intercostal retractions or cyanosis, which is the bluish discoloration of skin, nail beds, and mucous membranes. Next is conditions that affect perfusion and cellular respiration. Once oxygen moves into the lungs and diffuses in the capillaries, the cardiovascular system transports the oxygen to all body tissues and transports carbon dioxide from the cells back into the lungs, where it can be exhaled from the body. Conditions that decrease cardiac output, such as congestive heart failure or hypovolemia. Side effects of congestive heart failure can be found in the Fundamentals book, page 1297, which can include crackles in the lungs, shortness of breath, dyspnea on exertion, increased heart rate, S3 heart sound. Tissue perfusion can be altered by a disease process called atherosclerosis, which is the narrowing of arteries, and it is a common cause of impaired blood flow to organs and tissue. Ischemia is the lack of blood supply due to obstructed circulation. Depending on where the obstruction takes place, if it's in the heart, it's a heart attack. In the brain, it's a stroke. In the lungs, it's a pulmonary embolism. Peripheral vascular disease, which is poor circulation in the peripheral extremities that tend to be in the feet and legs. Signs of impaired peripheral arterial circulation in the legs and feet may include decreased peripheral pulses, pain or paresthesis, pale skin and color, cool extremities, decreased hair distribution. A Doppler can be used to assess the pulses in the lower extremities if it is difficult to palpate them. If there is any problems with inadequate red blood cells, low hemoglobin levels, or abnormal hemoglobin structure, this can greatly impact tissue oxygenation. Anemia has several causes. Either red blood cells are lost due to bleeding, diet deficient in iron or folic acid, low production of red blood cells, or disorders where red blood cells are broken down excessively. Some signs of anemia are chronic fatigue, pallor, shortness of breath. Now that you know about some disease processes that can alter the way we breathe, let's begin to start assessing the patient in order to collect data. First, the oxygenation history. A comprehensive nursing history relevant to oxygenation status should include the data about current and past respiratory problems, lifestyle, presence of cough, sputum, pain, medication for breathing, and presence of risk factors for impaired oxygenation status. An assessment interview regarding patient's history is found in detail at the top of page 1249 and 1299 in the Fundamentals book. To perform the oxygenation examination, first observe the rate, depth, rhythm, and quality of respirations. Note the position the client assumes for breathing. Inspect the shape of the thorax for indication of chronic respiratory conditions. If the patient has emphysema, they most likely will have what's called a barrel chest. Palpate for bulges, tenderness, and abnormal movement. Auscultate the patient's breath sounds. Assess skin color, temperature, hair distribution, lesions, and edema. Patients with extensive peripheral vascular disease may have cold feet with weak pulses. Pitting edema of the feet and ankles may be noted in clients with heart failure. There are several diagnostic tests we can use to assess our patients. This is a pulse oximeter. Make sure the patient's finger is warm and free of nail polish. These come in various forms, but they essentially all do the same thing. A chest X-ray will give a generalized picture as to how a patient's lung capacity is and if there are any obvious abnormalities. A pulmonary function test is a test that is performed by a respiratory therapist to check the capacity and the ability of lungs. A ventilation perfusion scan or VQ scan is performed in a nuclear med department to check the gas exchange in the lungs. A fiber optic bronchoscopy is a procedure done in an endoscopy department by a pulmonary intensivist. A scope is inserted down the trachea and into the lungs looking for signs of frank bleeding and/or infection. A PPD test is performed to determine exposure to tuberculosis, is a disease that can affect gas exchange. And of course, we can't forget about the labs that we can perform on our patient to check their oxygenation. Arterial blood gas is performed by a respiratory therapist who is trained. It will tell us how much oxygen is in their arterial blood, thus resulting in the exchange of oxygen that happens in the lungs. A complete blood count will show us red blood cells, white blood cells, platelets. The normal lab levels are found in your book under the lab section. The erythrocyte sedimentation rate shows inflammation throughout the body. The longer it takes for red blood cells to fall to the bottom, the more inflammation there is in the body. Sputum collection is outlined in your book on page 736 to 737. Sputum is not spit. This is the exudate that is found deep into the lungs that requires hacking, kind of essentially a loogie, into a cup. Notice the different types of substances that have been spit up. This is not spit. This is something different. Now comes the part where we can actually educate our patient on how they can improve their respiratory status. An incentive helps expand the lungs and open alveoli. They come in adult and children's size. It is good to put the mouth onto the mouthpiece, take nice, long, deep inhalations in, hold it, and then exhale. Huff coughing is the deep inspiration in, long inspiration, hold, and then coughing with kind of the sound of huff, huff. This helps loosen up deep exudate in the lungs. There's an exercise called pursed lip breathing, where a patient pretty much pushes their lips together. After taking a nice deep breath in through their nose, they're going to push all the air out for an extended period of time through pursed lips. Splinting is a method used for patients who have recent surgery. Splinting allows for extra support and restraint when doing cough deep breathing exercises following surgery. A pillow is placed over the surgical site pretty much the abdomen or the chest, and held tight simultaneously with coughing. Diaphragmatic breathing is extended to help you use the diaphragm correctly while breathing, to strengthen the diaphragm, to decrease the work of breathing by slowing your breathing rate down, decrease oxygen demand, and using less effort and energy to breathe. So let's try this as a class. Put one hand on your diaphragm, one on your chest. With taking deep breaths in, only moving your diaphragm out, extending it out like belly out, not raising your chest up when you're taking deep breaths in. Let's take 3 good ones. I hope you all did it. Now let's move on to leg exercises, which are very important, especially for your patients that are lying in bed. This helps prevent any perfusion problems, such as deep vein thrombosis. You're going to have your patient laying in bed with feet extended out in front. These are called ankle pumps. With one foot up from dorsiflexion to plantar flexion, they're going to alternate and do probably about 10 an hour. Now to do knee bends, you're going to ask your patient to bend their knee and then extend back out. And then repeat on the other side. They will do 10 of these each hour. This helps promote circulation. There are other devices called compression stockings. They're oh so fashionable, that also help promote circulation. Expose one patient's leg at a time. If they wear pants, roll them up so the sock is going directly on skin. You're going to make sure the sock is right side out. It's easier if you can roll it down to one, kind of like putting on a sock. But because compression stockings are a lot tighter, please be very careful, especially with your elderly patients. Kind of roll it onto their foot, make sure it's over their heel first before you start working everything down, and adjust accordingly. If your patient requires oxygen, there are several ways to deliver it. These are some ways to how the patient gets oxygen. These can be found in your book with your oxygen requirements along in the description. If your patient does require a humidifier, this is what it would look like. You attach the oxygen tube directly to the humidifier. To round off the whole presentation, make sure you review the NANDA case study at the end of chapter 50. That's on page 1281.